Okay, so a very dry topic, I think, but documentation, clinical coding and remuneration was the ask about what's the relationship between these. But I'm going to take it a little bit further and say, well, the relationship for me in what we do in the department in terms of how we look at all of this material in an activity-based funding environment, because it's very much close to my heart. So our classification, though, in the public hospital setting, for activity in hospital and health services, admitted patients are diagnosis-related groups, which are based on the International Classification of Diseases, Australian modification, and also the ACCCCN codes. I'm trying to think, what are they looking? ACCCN, so they're the procedure codes. Non-admitted patients are on a Tier 2 basis, and that's pretty much a simple description of the provider, not necessarily the patient characteristics. And then there's an emergency department, urgency-related grouping that is also applied in the public sector. Looking at the Medicare benefit schedule, that comes into play when we're looking at access to rights of private practice across the public sector and any opportunity in own source revenue or any itemised billing that might go on for private patients. In terms of the actual source of our documentation, at least pretty much everything comes from the medical record, a number of different places. I've got a YouTube clip which I thought I may as well play. Hopefully it works. Does it work on here? Does somebody run that? How do we get onto that one?
Try your mouse.
Let's click on it. I think it'll work. Oh, yep. So the Independent Hospital Pricing Authority often put out little blurbs about what they're doing and what's important in the system. Hang on, and obviously we've got no sound. Oh, we do, but it's not playing. There's these little jingle sets that go on a lot of the time. So in terms of where do you think information might sit relative to what you do on a day-to-day basis, Google's fantastic. YouTube, people have developed lots of little education packages, information, some clues about what might actually need to occur in a medical record to happen. One of the tension points we've got at the moment between what's being classed as the national standards and the ethical process for coding. Queensland's in a bit of a stoush with the National Standards Committee because for some reason it wasn't ethical for a coder to ask a question of a doctor, I think was how it was put in the documentation. And we went, what? That makes no sense to me, because you're actually trying to get clarity and improve documentation in organisations. So while these blurbs go on, it actually says that clinical coders are required to follow particular standards, but in our state and organisations we are absolutely expecting that everyone has the conversation and explores and understands what should be in that clinical documentation. I'll go back to here. So, yep, as I was saying, it was diagnosis, procedures, and there's comorbid details. But also, other clinical and administrative systems documentation inform the coding and the reimbursement that comes back to our organisations. So in terms of intensive care, the hours stay in the ICU, so there's a particular level of ICU identification, and the mechanical ventilation hours that are required to qualify under the national funding model for recognition as a payment per hour within the ICU. So there's different levels across the whole system. The patient demography is very important. So the age, the ethnicity, and also where are they from. So their regional rurality will actually influence the amount of reimbursement. But it also influences how the coding and the classification comes about. But most of all, it has to be clearly documented. Now, this is both in the electronic medical record and or paper records. Now, this is where we're having a little bit of a debate nationally, is the electronic medical record. So with the emergence of so much electronic media, what from that, what can a clinical coder actually abstract into the documentation so you get your classification for a hospital? I'll just get the clicky away. Often results are found in the pathology data, for example, but that can't be coded or used as diagnosis by the clinical coder unless it's actually written that there is a specific diagnosis. So we're just trying to get information together, and the best thing about the electronic medical record is the combination and the usage of linked information to see where information might actually, there might be gaps about that particular patient's conditions. The output of the documentation and clinical coding derives the classifications. The clinical costing data provides the resource utilisation. So we've got two data sets going on. One is the activity, what happened to the patient, and the classifications attached to that patient. And the second one is where that patient went through the system and what utilisation they picked up along the way. That'll be their stay in hospitals, stay in beds, their attendance at a clinic, their pathology, radiology and pharmacy usage is gathered. The price paid, both in this state and nationally, by the Commonwealth is based on the average cost of any given service within a classification. So, over 1 million admissions per year, are over 2 million non-admitted patient attendances, and about 1 million emergency department presentations a year are put into the classification. All of their costs are used to come up with the average for each particular classification within each of those categories. I've got an example of the DRG, the first few diagnosis-related groups on the list, and what the national model is actually saying about these, which is, so if I just go straight to a heart transplant one, nice and easy, everyone would do these. So in terms of the average length of stay of the heart transplant patient, it's 25 days with a range of 13 days and 121 days. So I'm assuming the 13 days didn't necessarily survive. But there's private patient adjustments. So in the national model, it recognises that there's a funding source that is other than the Commonwealth and state funding, state public funding that is. And there's also other adjustments around whether it's a paediatric case. And then there'll be a range of payments made depending upon their length of stay and other factors such as their particular patient characteristics. So a derived price, for example, a tracheostomy and or ventilation greater than or equal to 96 hours with major complexity is $152,000 in the national model. Minor complexity, and the average in the tracheostomy, if I go up there, was, tracheostomies, go to that one, major complexity, average length of stay, 36.9 days, with the minor complexity being 11.4 days. And that's $50,000. Now, the important thing to understand about how the pricing is actually set and the remuneration determined is it's the end product being a discharged patient. Now, whether that patient was discharged home, transferred to another hospital, they died in hospital, it's the aggregation of all of those cases into the diagnosis-related groups to come up with the average cost for those, including the average length of stay. There is some trimming, and that'll be super outliers in terms of their very short length of stays or their beyond 365 days or 240 to 365 days length of stay. So it's a trimmed component. There are also some categories of funding that are not included in the funding models, such as patient transport subsidy scheme. Depreciation is not a factor in it as well. Another example here would be retinal procedures between major and minor complexity. There's nearly a $3,000 difference in that particular value that is attributed, so actually the price attributed to those particular cases. And each patient episode through a hospital is coded, classified, and a price weight is calculated. And it's the price weight calculated that we call in our analysis the weighted separation, weighted activity unit, and the case mix acuity. So number of cases into the weighted separations will give you the acuity of the hospital, for example, or the acuity of a particular service. For the current funding landscape, there's Commonwealth, state and local sourced funding. And in terms of the Commonwealth funding from 14-15 to 16-17, the Commonwealth efficient growth was uncapped. And across Queensland, for example, we saw a fantastic growth in level of activity. And truly we're seeing a better transparency, I think, and identification of all of our cases that we're treating across the state. From 17-18 to 19-20, the Commonwealth growth is capped. So on the first point, our state was running at about between 10 to 14% growth per annum. It's now capped at 6.5%, so we're going to have to be choosing carefully those patients that we actually are going to treat in a limited growth funding environment. The other context that's coming in is sentinel events, or what we call in this state never events, will not be funded by the Commonwealth from 17-18. Previously, they were factors of payment within the allocations of growth. And this year it's being shadowed, but next year it's proposed to apply hospital-acquired conditions will be discounted on a risk-adjusted model from 2018-19. In this state, we've estimated that's between $50 and $80 million worth of movement in the actual underlying $4 billion we get from the Commonwealth. So that's quite a bit of money. Now, the Commonwealth isn't planning to remove it, but our change year on year will actually impact what happens across our hospital and health services in this state. And each state, I think, is actually planning to implement that slightly differently, but it's evolving over this year as we actually monitor that particular activity. So in the Queensland example, we use a state purchasing commissioning allocation method and to distribute new funding. It's based on demand. We look at demand of services, socioeconomic indexes of areas, and that's basically to assess the equity of access, performance in elective surgery and management of waiting lists, and localisations to recognise the tertiary services. And one of those being the intensive care units is a localisation that actually Queensland implemented before the national model actually changed to how we were doing it, because they were trying to look at an average rather than fund a particular service. What's important about this is at a global level, we don't meet what we're projecting as the demand on a state basis. We do meet the funding requirements, what's considered for the socioeconomic indices of areas, which is interesting, but it's in the wrong places. So we can see when we measure against socioeconomic demographics that we've got some problems in particular areas, and we need to work out ways to actually address that. So allocation of funding is part of the service agreement to our hospital and health services. This is the same for all public hospitals across the country, and all service agreements are public documents. They can be found on the internet. The hospital and health service then determines how they will internally direct funding and budgets to their own clinical services, which includes the ability to raise other revenue. So, for example, licensed private practice and grants sought. So there's another factor, which is funding that the Commonwealth and state don't manage, I would say, but it's within the remit of the hospital and health services to raise funds, depending upon obviously their case mix, the patient population ability to contribute to that, and the clinicians involved. Here's a bit of a messy picture, but it gives a bit of an example of where we're trying to head to in terms of 2026 because of the cap on our funding, and we've very much incentivised the system to go forth and make a lot of activity happen, reduce our waiting lists, especially the long waits. There's been a heavy focus in that particular area. We're just now trying to shift it. What is the value we're trying to derive from the services? How do we reuse what we're currently doing in a better way? And what do we shine a spotlight on? Because what we found with our funding models for remuneration oops, so it's gone on to the next one, is that when we put a signal out about paying for a particular service, it's rapidly taken up. When we've analysed some of the, evaluated some of the past quality improvement payments, for example, in this state, we've got that 20 million that we sliced out of the whole pool of money, and we direct that to particular quality improvement payments. But when we look at where those improvement payments have been paid against what the, say, the social difference or the atlas of variation or other signals, we're not always hitting the mark in terms of the investment is going where the most need has been identified. So we're trying to work out how do we get these closer together. So ABF has been fantastic. So activity-based funding is fantastic for identifying all the patients, all the activity. It's all pretty much, I don't know how to use the Monty Python term of bring out your dead, which is, you know, identify everything you possibly can, because then it's about where do we then align our focus to make sure that we get value out of the system at the right price. So I left it there, sort of more as a teaser and an opener. Do you want me to roll into...
Yeah, go to the next one, Tom.
Let's go into the next one. Is it linked?
Yeah.
So benchmarking. So for us, benchmarking is based on the views that we get of the system. It's very administrative in nature. Number of patients treated, our length of stay, hours in ICU, hospital-acquired conditions, the cost per patient, per weighted activity unit, per hour, and changes in health status. Now, our changes in health status is because at the moment we have a very small subset of data where we actually might measure changes in health status, but it's fairly limited. Others include mortality, readmissions to theatre, the intensive care unit or hospital, but in some of those cases we don't necessarily know that it was what was intended, what was planned, and or on a routine basis in terms of that particular case. We can look at the clinical complexity, and this includes the case mix variation across the state. And on the clinical complexity, Queensland, we compare our information with all the other states and territories as well, and this information is available on the National Benchmarking Portal. So if anybody has a password user ID that's in either the Queensland Health Network or any of the other jurisdiction internal health networks, they can access the National Benchmarking Portal and look at clinical complexity, clinical variation, and hospital-acquired complications. Of note, for those particular ones, there you can also pick up the ICU hours and the mechanical ventilation against the diagnosis-related groups. Where is it being used? And in some of the information we've been getting lately, there's been some national reports because the Commonwealth was quite concerned about the rate of growth that was happening across all states and territories, so they asked for an investigation into the activity and the case mix and where there was what might have been unintended or unexpected variation in activity. And one of the ones that came up as a highlight for Queensland was that we have the lowest rate of use of intensive cares compared to other states and territories. That's just a global statement. You kind of go, doesn't make sense, I'm not sure why. Are we more precise or prescriptive in terms of how we identify our intensive care unit, or is there something else going on? So benchmarking we use to really try and find a lot of the questions in the detail. So in this state we have what's called the System Performance Reporting, which has a comparison module, and it allows us to look at the national position. So there's some national links that we can be done. The one I'm going to look at next, which would be the National Benchmarking Portal. In this particular area, I've just selected the hospital-acquired conditions by state, and at the moment there's a pretty crude measure, but this will be the increasing focus for us because we do need to be sure that while our area focuses very much on We want to fund for the right care in the right place at the right time. So we've had a heavy focus on reduction of waiting lists, heavy focus on where the treatment might happen, and a lot of the classification models have actually been expanded to support that hospital avoidance can be counted. So if you avoided a patient coming into hospital, it can be counted in the non-admitted patient classification. Other areas such as community mental health, we've been battling with the national classification system to recognise community child and youth mental health, and apparently it's always been out of scope. In this state, it represents nearly $400 million worth of investment, and for that particular category to not even be recognised as a service within scope of activity of our services, we found pretty unusual. Adults were, why weren't child and youth? So these are the ongoing things we actually discuss and debate, but the current focus for us, and what's going to get probably most attention, is trying to get quality and safety lens into the funding models. And at the moment it's going to be managed through a range of benchmarking reports that actually they're pretty crude, and they will look at rates of hospital-acquired complications. When we drill down to the particular clinical services, we can see across hospitals that it's predominantly in the tertiary services, and which we would expect because they have the more complex cases. So it's kind of a bit of a catch in this. But what we want to understand is what are the areas that we should actually be focusing on to avoid? What should be improved? What is our improvement game? And our patient safety unit will be looking at and assisting us to help understand and unpack those particular things. But in terms of the benchmarking material, there is an awful lot of it. You can trawl through for days. A lot of research can be done just off these particular data collections that have been co-located into one particular system. So I wanted to basically give you a bit of a flavour of what's happening across funding and benchmarking in activity-based funding environment.
Thank you, Tony.
Thank you.